kind of responsible for this to the county board of commissioners. And that group is known as MKIDA. MKIDA is Kenya Minnesota International Development Association, a group of Kenyans who have come together to see how we can give back to the communities where we live in, including Minnesota, and giving back to Kenya. And my name is Gerald Nyachai, and together with me is Jared London and Maseras Mayaka behind there. He lives in Bremouth, I live in Bloomington, he lives in Hopkins, and Hespon, he lives in Elko Market.
Oh, okay.
Yeah, way south.
Yeah, thank you very much, Tom.
There is the gentleman with the camera here is also from Kenya. He lives in Shakopee.
Okay.
Yeah.
Good.
Thank you very much. These two counties are sister counties in a sense that Kenya has 47 ethnic communities, what we call tribes, and there is one tribe called Kisii. They live in the southwestern part of Kenya, near they call the Victoria, second largest lake in the world, 30 kilometers away. Now, these two counties used to be one county, but they were administratively divided about 15 years ago. So the one that I'm heading has about 1.3 million people. The one that my other colleague who didn't come is heading, called Nyamira, has about 600,000 people. So we're talking about a total of one ethnic group that talks the same language, same culture, same issues, about 2.2 million people. In Kisii County, we have one hospital which is a level 5 hospital, which is supposed to be having all facilities, including equipment, including specialists in the various areas, whether it is in pediatrics, whether it is in renal, whether it is in whatever specialization. We have another level 4 hospitals with about 8 of them. Level 3, which is like in our place we call them not health centers, no, sub-district hospitals. They are about health centers, I think they are about 83. And then the dispensaries are about 71 of them from where I come from. The problem we have is that, and that is in the context of curative services. In Kisii County, that one hospital we have, which is supposed to be our high-level hospital, takes care of, it's the high-end hospital that is supposed to take care of the 1.3 million people. The problem is that this is an hospital that probably may not be having all the equipment, they don't have an MRI. For you, that will be a very simple equipment. If it's orthopedic surgery, they will not have any equipment. The renal surgery, they don't have anything. They don't have anything for us. They don't have cancer treatment, they don't have. And for us, that causes many problems. If you go to the area of preventive services, our top mobility causes are like malaria, diarrhea, urinary tract infections, pneumonia, HIV/AIDS. We have serious problems with mortality in children. Some of them would actually relate to birth. Some would relate to malnutrition. Some would relate to diarrhea and anemia and so on. Very basic things. But probably because of the level of funding that we're getting we used to get from the national government. Now that we are county government, we want to understand how to manage our resources, how to manage our healthcare system. The devolution system that you see in Kenya that has created the county governments is 5 months old, 5-6 months old. So we are actually institutionalizing the new system of governance where we now have resources that we are governing ourselves. Like as governor now, we've been given resources to manage health services. The issues for me relate to the amount of those resources, it relates to capacitation, it relates to infrastructure, it relates to equipment, it relates to fairly many things, even the lack of ambulatory services, and so on. So we basically have come here to share experiences from Hennepin County, to see to what extent can we learn from you. Can you hold our hands as you start working? If it's possible, but can we learn from you so that the type of institutionalization that we put in place is an institutionalization that makes sense? The type of problems that very few are the problems that we are in here, which is the next county. We have one hospital on the county headquarters, which is supposed to be a level 5, like the one that is in our county, but whose configuration is of a level 4. Even the things they don't have those things that I've told you, and worse. Their sub-district hospitals are almost non-existent. What they have are actually health centers. In a basic health center, what you would find is you probably find a clinical officer, you will not find a doctor. You find a clinical officer, you will find nurses. You probably might find simple equipment for testing like malaria and other simple diseases.
And painkillers.
And painkillers. Yeah, if somebody goes there is sick, he'll probably be given painkillers.
Yeah, that's it.
He or she will be given painkillers. So what are our issues? Our issues are the one hospital that we have, which takes care of both the two counties, because the administrative boundaries really don't matter when somebody is sick. We have had discussions with the local university to turn it into a teaching and referral hospital, and the university is creating a medical center, and we also are seeking support so that we can turn it into a complete teaching and referral hospital, which means that it must have all those specializations, including the related equipment and everything that will support it. We are talking about X-rays, we are talking about MRIs, we are talking even simple things like beds and so on, because if you are going for, there are specific beds that people in the medical field use, that the patients use, which may not be normal beds. We are talking about putting in place a fairly modern maternity wing. We are talking about putting in place in the two hospitals diagnostic centers, both for renal cancer and all the other major ailments. So that's the type of scenario, Tom, that we're talking about. It's a bit fairly scary, but for us, we are almost starting from scratch. And so we've come here on a learning mission. We have also come here to see whether there are any possibilities of counterparting with Hennepin County. We have also come here to see to what extent what you actually think is old equipment and useless equipment, to what extent can you be magnanimous enough? Because if that equipment came to my county, for instance, it would look like the latest technology. What probably you would decide that it has done 10 years and there's new technology. For us, it will be the newest technology. So I think broadly speaking, we've come here to share experiences. We've come here to know the brother. who has been around for quite some time to show us how best we can move forward as a new county government. In Kenya, here in the US, you have 3 levels of government. You have federal, you have state, and you have county. In Kenya, we have 2 levels of government, national and county. So we have 47 counties, that's 47 governors, and 1 national president. And the person who is talking is one of those 47 governors. I don't know where Professor went.
Right here.
Yeah, Prof, you want to say something about Nyamira?
Thank you, Your Excellency. I will defer to Dr. Ongwae, the Director of Medical Services, to say something because I know this is so.
Thank you very much, Professor, and Your Excellency. I think His Excellency has captured very well the issues that deal with health in both the counties of Nyamira and also the county of Kisii. Basically, like he said, we are about 5 months old. You guys have been around for quite some time. We are beginning to set up systems from the national government to the counties so that we are able to run our health systems more independently and in a more focused way. And one of the things that has brought us here is to learn how we are doing our things. Some of the things that currently we are dealing with as health services, apart from what His Excellency has mentioned, are emergency services. He mentioned ambulances, basically how to set up the referral services within the counties. For a number of years, we have been dealing with the communicable disease only. And in the recent past, we have emerging challenges of non-communicable disease. We now have quite a significant number of people who have cancers, heart disease, diabetes, among other things that are more complicated and more expensive to manage. And the scenario that you described regarding the medical diagnostic equipment and the other things really are at the center of it. We have a lot of health facilities that are able to diagnose simple heart ailments, diagnose diabetes, diagnose simple cancers. Therefore, a lot of people, by the time they get to the hospitals, the big hospitals, that is in the major cities, you are almost talking about terminal stages of cancer. So really, those are some of the issues that we have come to learn from you. And I know another thing that I think in your country, you have very well organized systems of financing health services. I think you have very well developed health insurance systems. We are just beginning. Our penetration levels regarding health insurance is very low. I think in some areas as low as 10%. That means a lot of people have to pay for health services from their pocket, which is quite expensive. We are also learning, we have also come to learn how you have set up your systems to finance health services, both from the preventive angle and also the curative health services. So this is some of the broad issues that we've come to learn.
Actually, the health financing penetration levels you talk about of 10% would be extremely high. I think in certain areas it's even less than 5%, if you ask me. And even that financing would not only support the curative part, isn't it? The more preventive part, the walk-in, walk-out, is not supported, and yet you want to manage the preventive side much better so that people don't reach to the stage that they are getting into the curative part of it. So we'll probably, Tom, I don't know if that gives you enough indication of
that's
what
very
it
helpful.
is. I hope it doesn't scare you.
No, it's very helpful. I appreciate it. I would start by saying congratulations on 5 months. Congratulations on the organization into counties. I want to, part of what I'll talk about in the presentation will cover some of what we've talked about, but I want to first introduce Dr. Karagu, who came a few minutes late, who is our Assistant Chief of Pediatrics, and he's the Medical Director of our Pediatric Intensive Care Unit.
Henry Kirandi.
Yeah, and introduce yourself, please.
Dr. Henry Kirandi, I'm also a doctor in this hospital, but we haven't met.
Right. Yeah, we haven't. So,
Yeah.
thank you for coming. So, so they're going to participate and also participate on the tour. I hesitate to say this because it may not come across correctly, but healthcare is really difficult, as you can tell in the U.S. right now, where the federal government is partially shut down, in some ways because of the major fight over healthcare financing in the United States and a change in the insurance system here, what's called the Affordable Care Act, or some refer to it as Obamacare. It is a new system of health insurance nationally, and it causes great political tension at the federal level, and because of that, part of the federal government is shut down. So I say that only to say it's really a challenge to provide healthcare services to a country, to a county, to a state. And if you go to 50 states here, you will see 50 different ways that people provide their health services, or pay for, I should say, their health services. We're very fortunate in Minnesota to have a what I would call, I don't know if the right word is generous, but a very mindset of believing that everybody deserves access to health care. And to do that, everyone needs some level of insurance coverage, although we have a lot of self-pay. We have a lot of patients here who have to pay out of their pocket, but it's because of the insurance in Minnesota and the public programs, it's better here than it is in many states where they have literally tens of thousands of people who don't have insurance. And as you said, if you're sick, it doesn't matter where you are. You know, you deserve care, and whether it's crossing county lines, we have that same situation. We believe if you're sick, you get care whether you have money or not. But of course, somebody has to pay for it. Somebody has to keep the lights on, and somebody has to pay for the equipment, and so it's a challenge in the United States as well. So let me show you a couple of slides on the screen to tell you just about Hennepin County Medical Center. I might move kind of quickly because some of it might not be as relevant, and I want to make sure to save some time for the tour. But I'll just tell you a couple of things, because there are some real similarities to what you've described with the new hospital, or the new model that you want to create with your university. So it has been around a long time, since 1887, and it did start, in our case, as a city hospital, Minneapolis, city of Minneapolis, and it literally started in a room, in a house, and I believe the care there was 84 cents a day was the cost of care. Where it started, and it was a matron and very little staff. And it moved to still a city hospital, but it moved to an independent facility, or a new facility. It's called the General, and that was really around from early 1900s until until the mid 1970s, when that hospital closed and we moved into this building. But it transitioned. So it was the Minneapolis Public Welfare Board institution until 1963, and then Hennepin County took over management of the institution. And you've already met, I think, Commissioner Opat, the chair of the county board. The county commissioners, the Board of Commissioners, ran this hospital from 1963 until 2007. They are still involved, but again in 2007 there was another change. So you think that's the third major change in how this system is run, and that was they created something called a public subsidiary corporation. So that's somewhat separate from the county, though still owned by the county, but now we have a new board of directors, and those are citizens. So instead of the county board managing the operations, a board of citizens, I call them citizen experts, because they're people who have expertise, like around this room, people who have expertise in healthcare or finance or human resources or public policy or education. Those are our board members. We've got about a 12-member board. We do have two county board members, so Commissioner Opat and another commissioner are on our hospital board. So there's still a tight connection. But people who work here, like me, aren't county employees anymore. We're employees of the hospital. And these buildings that you'll see are leased from the county. So the county still owns them, but we pay, I believe, $1 a year to lease the facilities from the county. So, pardon me?
Did you say $1?
$1. So it's more of a ceremonial, so the county doesn't want to set us back. But on the other hand, it has to be a transaction like that. But we do, you were talking now about ambulance service. So the Hennepin County does operate the ambulance service. These are a list of communities, Hopkins, Hopkins and other cities within the county where we provide ambulance service. In this city, or in the state rather, ambulance services are divided up by primary service areas. So these are our cities, but then another hospital system has a number of cities that they provide ambulance for. In some cases, the fire department in the city provides first response as well. And then, speaking of primary care, and I see that you're going to North Point tomorrow, the North Point Clinic. That will be good because a lot of your questions and a lot of information about how primary care is delivered, preventive care can also be answered during your visit to North Point tomorrow. But this hospital has a clinic system, and it's a growing clinic system that's in a number of communities. Richfield is down south by the Bloomington area where one of you is from. And then really across the county we have clinics. These would be equivalent to your dispensaries or your level 3, I suppose, your clinics, your primary care clinics.
Will probably be equivalent to our level 5.
Oh, okay.
No, actually, those are the health centers.
Oh,
They
oh,
are
that's your
health
health
centers.
Yeah, but supposed to be, you know what I'm talking about is the facility.
Right.
Like everyone, the facilities. And the infrastructure. Yeah.
So this is a different kind of level now, where these are, we have something in this, in Minnesota and nationally here called the trauma center designation. So your different levels of trauma center. A level 1 trauma center can take most anything. It means it's prepared for most any kind of treatment to provide the highest level of treatment to accident victims, stroke and heart attack and all the traumas. So we're a level 1 adult trauma center, a level 1 pediatric trauma center, and then also a verified burn center, certified primary stroke center. So I just show that to you to show that's a kind of a level of accreditation for those services, and we will go and see the emergency room. So this gives you an idea of the scope then of this hospital. There are 140 hospitals in Minnesota. There are about 30 hospitals in the metro area here, so we're one of 30 hospitals, but we're one of the largest for sure. We have 462 staffed beds. Almost 22,000 inpatients are treated every year, so they come in, stay overnight for hospital care. About 100,000 people come through our emergency department in a year's time. 500,000, so 500,000 clinic visits to our clinic system, about 2,300 babies.
What is the doctor-patient ratio?
Doctor to patient ratio. So we have
In broad terms.
350 faculty physicians. Does that sound about right? About 350 faculty physicians, and then other providers. So I'm not going to do the math standing on my feet of the doctor to patient ratio, but what I'll get to is also, so that tells you how many physicians provide care within these numbers, but what I'll get to is we are a training hospital as well. So we have residents in the residency complement as well. So the physicians, it's an outstanding group of physicians recognized within their specialties, recognized within the community in various publications such as that. And then we have 6,000 full-time employees. So these are just different recognitions that we've received for being an employer. But anyway, to the bottom line on this side is there are 6,000 full and part-time employees who work in this healthcare system. So back to the question of physician ratio and what you said earlier about a connection with the university. This was the first off-site teaching hospital of the University of Minnesota, and remains its largest partner, its largest off-campus partner of the University of Minnesota. In addition to all of the residency programs, and there are 16 residency programs and partnerships. In addition to those, we're also the clinical training site for all sorts of other health professions. So nursing, emergency medical services, lab, pharmacy, we're the training site. Students come here and train on clinical rotations, or maybe even just attend a class or a series of classes. And so we really consider ourselves vital to train the healthcare workers for Minnesota's future. Another role that we play is natural disasters or emergency situations. So a couple that come to mind, we had a bridge collapse about 7 or 8 years ago while it was in rush hour and full of traffic. So we're the primary receiving hospital because we're a level 1 trauma center because of our location. So we do a lot of emergency preparedness, a lot of drills to prepare for emergency situations. And then this slide here, just to tell you a little bit about the payment structure. So I mentioned that the best scenario in our view is to have as many people have health insurance as possible, because then they get the care they need, both care to stay well, preventive care, and care when they're sick. So that's why for our basic income, 95% of our operating income does come through payments that are for the care of patients. So that might be that they're on what we call a private insurance or commercial insurance, like in this country a Blue Cross Blue Shield, something like that. Or it might be that they're in a state program and the state is paying us. But almost all of our revenue comes from those payments. 5% does come from Hennepin County directly, but that's to pay for the care of county residents who don't have insurance. And I don't have it on the slide, but our annual budget is about $750 million. That's the annual operating budget of Hennepin County Medical Center. And then a point that we make when we talk to citizens is that we provide a lot of uncompensated care, a lot of charity care, a lot of situations where we're providing care that costs more than we're getting paid. So we consider that a community contribution. And that's actually something we have to calculate every year. So this is when we're talking to community groups locally. We point out that we certainly encourage them to choose HCMC for their health care, and that we do have a philanthropic opportunity for people to support us through philanthropic donations as well. So that's kind of what we might call the 30,000-foot view of our hospital and clinic system here and our financing. Before we go on a tour, are there any questions about anything that I either passed over quickly or I didn't touch on something to be of interest?
I've got a question. Probably when our governor was trying to compare the hospitals here and back in Kenya, there is a little bit confusion about level 1 and level 5. It's a little bit confusing. So probably one of our doctors probably can try to explain, but it can actually be in a good position for him probably to highlight some of that information.
So the levels of care that people talk about vary depending on the services that are being provided. So in the case, say, of a newborn intensive care, the highest level of care would be a level 3 nursery or a level 3B nursery, whereas and then if you're talking about a pediatric ICU, you're talking
it's upside down. And the level 1 is the highest.
Level 1 is the highest.
But I think it depends on what you're calling them. It's just an universal. And I think the categorization is different from. This is a different issue. At home, we are talking about the categorization of hospitals according to the facilities they have. Like you could have hotels with 5-star, 4-star like that. So that's different from.
So level 5 would be closest to our hospital. I mean, I realize there are differences.
Yes.
You're talking a fully
Yes.
functional
And
hospital.
Yeah.
ours the lower levels really are performing both preventive and curative, much more on the preventive.
Exactly. I think in Kenya we have what we call Kenya Essential Package for health, where we look at the population in terms of cohorts, and we grade the health facilities based on the level of care they're able to offer. We start at the community level, what we call community health services. Basically, we have a group of 5,000 people living in a village that is organizing themselves in a manner in which the government is able to interact with them in terms of preventive health services, where we have people volunteering in the community to help each other from household level in terms of health education and basically health promotion. And from that group, we have the dispensaries, which is now essentially the first contact of formal care, where basically most people receive preventive health services, health education, immunization for the children and for the pregnant mothers, distribution of nets to prevent people from getting in contact with the vectors that spread malaria and stuff like that. So it goes that way up to a level where we have integrated comprehensive health services. We have curative that His Excellency was talking about, together with some level of preventive care also. So it's actually inverse, rightly as put by Dr. Kirangi. What you call your level 1 is probably the other end of our.
Yeah, I think you're right. It's allergic reaction. Tomorrow, and I think when you go to North Point tomorrow, you're going to see akin to the dispensary in terms of the kinds of services. To your point, that we'll have technology and things. But, yeah, that's our basic system as well.
Yes.
We have to be very careful about terminologies, especially because they are quite different.
Yeah.
Like you may say, like you were saying, a clinical officer. Here we don't have a clinical officer. The equivalent we have is a physician assistant. So there are going to be a lot of terminologies which we have to be careful on how we say about like health centers, like community hospitals, something like that.
Health centers, you're actually talking about community nurses, isn't it?
Yeah. And there is also, we may say, a nursing home here, a home there, private hospitals are called nursing homes. So we have to be very careful on the terminologies, and we'll learn as we go by. And that's why our reason of the team coming to Hennepin County Medical Center is to get the grasp of what happens here, then apply home and see where can we place Hennepin County back home in Kenya, if it can be placed. And then to create relationship so that Tom and the rest of the hospital can visit Kenya and see what happens. And then from then, when we talk, we understand each other where we are.
Monday?
Very well.
We'll see.
A quick question for you. A quick question.
Yeah.
What is the role of the private sector in ambulance services?
I think that's good. I think let's start. What's the role of the private sector broadly in the whole area of healthcare and also in the whole area of ambulatory services?
Well, it's different in different states. So in Minnesota, you cannot, we don't have corporations-owned hospitals in Minnesota. In other states, there are corporate-owned hospitals. So there are some giant healthcare corporations that own hospitals in other states. In Minnesota, you have to be a not-for-profit organization to own a hospital. Now, they're big, and they generate a lot of revenue, but they don't have stockholders. But if you visit other states, Arizona, a lot of southwestern states, you'll see a different model. Same with ambulance service. We don't allow private ambulance services in Minnesota. It's just the way it is. It's the way the legislature constructed things. Ambulance services here are owned either by the hospitals or fire departments and municipalities. So we don't have privatization here.
The setup also of trauma centers, I find out, for instance, in our own counties, we now have motorcycles.
That keeps trauma centers busy.
They're actually in their thousands. And but trauma center for us is something that would actually be is crucial.
The original structure.
We don't have any, isn't it? We don't have what you can call a trauma center.
Actually, we don't, because a trauma center, looking at even the personnel that described here, I think in the 2 counties we have no trauma surgery. So
No, we
don't
don't
have a trauma center. What we have a general, just a general hospital,
Yeah.
not to that level that you can actually call it a trauma center. Or a pediatric specialist like the guy was talking about. I think we have 2 in the 2 counties, or a population of 2 million, so you can look at the situation. But His Excellency had very good input. Overall, you're saying that private sector is not so much involved in running of health services.
Not in the state of Minnesota. In the U.S., though, it's not uncommon in other states to have privately held or privately owned hospitals.
So even these clinics are run by the government?
Well, government or their nonprofit corporations. So it might be some of it a little bit a matter of terminology.
But again, it comes to terminology again.
Yeah.
Actually, services are not free. Let's put it that way.
That's correct.
They are paid for. Even the ambulances you see, they are owned by the county. You still pay for them. Insurance pays for them, you pay out of pocket. So we can still say in the courts they're private because they are not free in Kenyan terminology. Okay? So you have to pay for them, they have to be accounted.
My last question. Basically, we are privileged to have very hard-working Kenyans here. You see, we have got 2 doctors here actually serving the community. We appreciate for that opportunity. And we would love you also to extend this particular opportunity probably to the community back in Kenya, in kind like the way Mheshimiwa, we call them Mheshimiwa or Honorable, or His Excellency.
He has not refused actually.
Thank you very much.
You said Monday, right? You said Monday.
I'll be there Monday.
So basically, what I was actually
My
trying
wife
to
might have something to say.
I had not finished my my request.
Yeah.
The other thing is probably we would love to get a level whereby probably what they are calling residency here back in Kenya, we call it internship. So probably if it's a cool idea for us probably to have a close working relationships, and our friends here probably can be sending some of the doctors down there to those hospitals. Probably they can be helping us, and we are really here for a big operation. That's what we are really requesting. Thank you.
Yeah, does anybody have any issues? If you don't, then after that you keep your mouth shut. Like they say.
I have one thing. Dr. Kirandi and Dr. Kragu are probably more familiar with what we are talking about than anybody else. We are, in fact, in this room because they do understand both sides of the spectrum. I would love to hear what Dr. Kragu will say before we go on tour. Just like Dr. Kirandi said something. Dr. Kragu.
Specifically about what?
I like that.
I think what you need to ask Kiragu is you need him to put things in perspective, and you probably need him to help us understand this conversation that we are having about a relationship with Hennepin County. How can you make this relationship work? Is it something that's possible, or are we trying to look too far? Can you solemnize the friendship?
I think there are opportunities that exist for collaborative effort between health facilities here, specifically Hennepin Fundamental Center and the health facilities in Nyamira and Kisii County. I think, there are a number of physicians who work at this hospital who do, what people would call mission work in Kenya. Some are Tenwek, other people go to Kijabe, other people go to Kenyatta. Eldoret. So the capacity to do collaborative work is there. Ideally, what you'd want is an exchange. So, for especially as you try and work to develop capacity in the different counties. If you have folks that you want to get additional training, come for a few months, get some ideas about how to work on certain things, have folks from here travel and help, kind of with setting up different systems. I mean, I think the willingness to have something like that happen is there. In the US, I mean, but one thing that's important is to realize that even though that willingness is there, there are some, of course, hindrances to this process. So, but people do help where they are able to.
I think before you close the line, how do you get your drugs? Do you manufacture them or medicines? Yeah.
I think that's something very important actually with what
you source your
the whole issue of drugs in the pharmaceuticals and so on.
It's not my area of expertise. We buy it on the market from big pharmaceuticals that you're probably aware of.
Now, is it a centralized distribution system, or each clinic just basically goes to buy it?
The system purchases for the system.
For the system.
Yeah.
And I mean, so again, it varies from state to state, hospital to hospital, system to system. So there are situations. So, like say, currently. Hennepin County Medical Center has partnered with a larger health system, in this case, Alina, to have an agreement with regards to how we're going to purchase medication. So that because you are now coming together as essentially as a big buyer, you are able to get a better deal.
Dr. Kirago, one further question before we get off track from that specific statement that you put in place about collaborative efforts and exchange programs. That might be, if I can follow up that with a specific question, how, if they wanted to go about that, how can they do it and who can they go to in furtherance of that collaborative efforts?
Solemnization, formalization of that kind of collaborative relationship would go through the executive leadership team of the hospital and the Office of the Medical Director. The Office of the Medical Director, through that office is where a lot of the education and a lot of the exchange programs will occur.
What is it on that, Kirago? The doctors that come from Kenya, who have come for a training program here in the hospital, they have to undergo certain procedures in medical boards before they are allowed to
So it depends. If they are coming on an observer basis, the process is not as difficult. I mean, you do some background checks, you get some, you fill some paperwork, and then you have an arrangement with a group of physicians that you want to work with. And in fact, right now I have one physician from Kenya who is rotating, who is doing an observership in our Kids ICU. So she comes a couple of times a week. She'll go on rounds. So that's an informal. It's formal, but not in terms of training. Now, if you want to come say and to be a registrar, to do now more formal training. Now there, the process becomes now a little bit more complicated. Dr. Gandhi, Dr. Ongwae, a number of us have had to go through this process. It's a bit more difficult. Then there you have to go through formal examinations, apply for a residency program, competing against Americans and people from other places that want to get into the program.
And to answer on that is, I know what you want. You base your question on this. Here, you have to be licensed to practice. Now, when you come for training, it's difficult because you cannot put your hands on a patient if you are not
And that's
licensed.
what I was waiting for you to say.
So you cannot. That is, those are regulations, those are state laws, and they're all over the U.S. You cannot do that. Until, as you said, if you want to join residency program, then you go through that process of being licensed. Because even the residents who are training here, you have to get a Minnesota license before you start seeing patients. So, and again, on the drugs you were asking.
Maybe before you answer with this one, will you go ahead and work through a website? Is it possible to run through the website and information?
Oh yeah, these days medical education has become so much on the internet, electronic. You can learn. You can pay for it. Even here at this hospital, the hospital pays for us to learn that material. Even if we want it now, even doctors in Kenya. Actually, someone I think is in Tenwek, is a U.S. citizen, is trying to design a website for the Kenyan doctors that they can use their cell phones to access medical knowledge or medical information when they are seeing a patient. So it's possible, that's possible.
Will that be the first Solomon?
Let's be honest.
Yes,
Let's be honest, please.
And on the medications you were asking, again, terminology is coming.
Yeah.
In Kenya, medicine has been coming, the level or the medicines come from the central medical stores to the patients. Okay? Because it's a national list. Here it's not. You buy your medicine. Okay?
Thank you very much.
So it's not.
Tom, I don't think that we are serious questions.
Okay, well, we'll take a tour. A couple of things. We were talking about regulations in the U.S. One of the regulations here that we honor is what we call patient privacy, or it's a patient's right to privacy. So we're not able to take film or snapshots or anything like that, phone shots or anything. With a group this large, it can be kind of hard to tour because it's just a lot of people moving through. So I was thinking, and you may have some feedback, we would go over to the emergency department. We could move through the emergency department. Would it work to go to the PICU, or would that not work? I'm not sure what that
Probably work.
would work.
I'll add quickly that not all of us will go. There are those that specifically will be geared to the medical departments, and probably some of us will stay behind.
Okay.
A few of us will stay behind.
Okay.
And before they go, we'll say where we'll meet.
We'll
after.
pick you up. Yeah.
Yeah,
Okay.
so
We can do that.
just in case.
There is a
I know,
coffee
I
shop
understand.
right upstairs.
Yes,
Yeah.
I
So,
understand.
and then I thought the Sim Center maybe for training purposes, and there's somebody down there. So we covered those three areas today. We're on a 5-block.